So today the bite-sized teaching is on a protocol for antenatal detection of hydronephrosis, and mainly be focusing on the protocol and pathway. The picture here is something fascinating I came across when searching internet for fetal ultrasound, and there was an article questioning whether dolphins can actually see the fetus using the sonar waves, which I thought was quite interesting. So today we will talk about a little bit of a background and some evidence available, but mainly about a protocol. Please, can someone confirm that you can hear me and see the screen?
I can hear you and see the screen.
Lovely, thank you. So, since the start of the ultrasound technology in maternity clinics, there was, as to be anticipated, increased detection of abnormalities, amongst them hydronephrosis, which is one of the most frequent ones. But we quickly realized that it's just a picture and not a diagnosis. So obviously, whatever we saw need to be interpreted, and then after the baby was born, investigated to find the diagnosis. So what is the goal or challenge in finding good protocol? Firstly, to identify patients with significant anomaly, and also to avoid unnecessary testing of patients with physiological changes or clinically insignificant hydronephrosis. So the thresholds are one of the problems to be identified and established in a perfect protocol. I mean, to what extent the renal pelvic dilatation is physiological. We know that thresholds may vary with gestational age, and to take into account the variations that are there in the literature, the variations in definition. And then which investigations should we commence and when? Should we use antibiotic prophylaxis? And if so, then in whom and for how long? The protocol should be simple, so anybody without any significant depth knowledge can actually follow, and reliable, so giving us some reassurance that no babies are missed. And now some evidence base for the principles of our protocol. So what we do know from the literature is that renal pelvic dilatation is frequent and sometimes just a phase of normal, that the size of the pelvis correlates with clinical significance, and you've got the references there in the red, just in case you wanted to find out more in details. Then we know that one postnatal scan is not enough because the babies are not volume challenged, as I say it. So without really good feeding, there is initially physiological oliguria, and the kidneys that may be truly quite dilated are not really showing in the very first hours of life. So we know also from the literature that 2 normal scans, 4 to 6 weeks apart, are safe to exclude the problem. MCUG is not and should not be the first line, but actually it is the only reliable test for reflux. And also we know that routine antibiotic prophylaxis, CAP used here, abbreviation, is not recommended. Problem with antibiotics is long-standing. Theoretically, hydronephrosis predisposes to UTI, and hence in 2009, for example, in the USA, the continuous antibiotic prophylaxis was recommended routinely to all detected renal pelvic dilatation. Later on, this recommendation was questioned, not only because there was increasing antibiotics resistant globally, but also there were no clear evidence that it is beneficial. So what is the evidence out there available? There was a systematic review performed in 2013 by a really reliable group, Canadian group led by Braga, And this systematic review titled Antibiotic Prophylaxis for Urinary Tract Infections in Antenatal Hydronephrosis. There were about quite a few citations, but only 21 included, 76% unfortunately low or moderate quality, quite a good number of infants. What they found that low-grade hydronephrosis, in low-grade hydronephrosis, there is no significant difference in number of episodes of UTI with or without the use of antibiotics. But in high-grade hydronephrosis, there is significant difference in these infections. So therefore, the continuous antibiotic prophylaxis was recommended for high-grade renal pelvic dilatation. These are the graphical representations of the numbers. So you see in low-grade hydronephrosis, the number of UTIs, whether they are on antibiotics or without, there is really no difference, 2.2% versus 2.8%. But in high-grade hydronephrosis, the number of episode of infections is double when there is no antibiotics. So in low-grade hydronephrosis, another visual representation, no difference whether you use or you don't use the antibiotics, but in high-grade hydronephrosis, the use of antibiotics reduces the number of infections by half. Another systematic review performed a few years later in 2017 by the same group looked into more details into aspects of the renal pelvic dilatation. So this number of studies reviewed, 11 included, 4 considered actually high quality, about 4,000 patients. Excluded were small studies when there were only 10 patients, or there was insufficient information on the use of antibiotics, or just review articles. The primary analysis included the use of antibiotics, the gender of the baby, the circumcision status, and the grade of hydronephrosis. This is the forest plot for that study, and they concluded telling us what the risks are for the UTI in hydronephrosis. So the risks are high grade of hydronephrosis, being female, of reflux, and absence of circumcision. It's worth keeping an eye on this author there, who's one of the authors of the systematic review, because actually the group then decided to organize a randomized controlled trial comparing trimethoprim to placebo in infants with significant grade of hydronephrosis. It's apparently underway, so it would be good to find out when it comes out. But in the meantime, an Australian group performed another systematic review for long-term antibiotics for preventing a recurrent urinary tract infection in children. 16 studies, 7 compared 2 or more types of antibiotics, 6 compared antibiotics versus placebo. One study had 4 arms, branching depending whether there was circumcision or not, whether there were antibiotics or not. One study used different doses of antibiotics, and one study had 3 arms, 2 different on antibiotics and no treatment. So overall, it was a very varied approach, and pulling of data was challenging, as you can see. But they draw these conclusions. Long-term antibiotics may reduce the risk of symptomatic UTI in children who have had more previous UTIs, but actually benefits may be small, and there is increased risk of microbial resistance. Just a quick look to what others do. Abroad, in country A, you see the threshold is used of 5 millimeters. In country B, 4 and 7. You can see that some people decide to use ultrasound on day 1 and then MCUG quite early on. In the other country, postnatal scan is delayed to day 4 to 7. Then country A, they also do follow up for family history. What happens here in the UK, 3 different cities were confirmed. So you see in city B for severe renal pelvic dilatation, babies get MCUG straight away. Scan is done in the first week, MAP3 is used, and they are actually admitted even to neonatal unit in CTA. Antibiotics in CTC are used for all, but not in CTA and CTB, so quite a lot of variations. So we've taken all that into account, and this is how our own protocol evolved. We started off with this, which is quite historical. You see that the author was Dr. Chris Reed with Judy Rissick, who was our neonatal associate specialist back then. That was September 2003. You see that the threshold for renal pelvic dilatation at the time was 5 millimeters. I'm going to tell you that the BAPM recommendation then changed since then, and we are now using different thresholds. We'll come to that. The threshold for severe was 15 millimeters, and you can see it was branching out, but you see the protocol was quite complex, and it also included quite invasive investigations like MAG3 quite early on. We were very privileged to have the urology, pediatric urology team developed back in 2009. Ms. Patil joined our team, and then the team grew. So we've drawn our first protocol with in cooperation with the cooperation with the urology team in 2010. And this scheme overall principle has not changed since, but some just details changed. But basically it's divided into the group of high risk with male infant with bilateral hydronephrosis, the moderate group, and the low risk group at the bottom. At the time, we were using trimethoprim in all three groups as prophylaxis. The threshold, as you can see, were varied from 7 to 10 to 15 millimeters. And this is the current protocol that we've developed in 2014. It takes into account the measurements in the third trimester, but we still have the three groups: high risk group, moderate, and the low risk group, with the caveat of the additional ultrasound findings are like calyceal dilatation or ureteric dilatation or parenchymal thinning, which on its own increase the risk of pathology within the urinary tract. And if we find something like that in the antenatal scanning, then these patients become moderate risk group. So let's look into details in the high risk group. This is high risk group with when there is a male infant with bilateral dilatation of more than 10, because less than 10 in third trimester is actually normal. You remember the old protocol had 5 millimeters as the threshold, and a few years later it changed to 7, and now it's officially 10 in third trimester. So any boy who has bilateral dilatation is obviously at high risk of PUV. Therefore, it needs to be quite aggressively investigated. And we start them on trimethoprim. We do ultrasound within 48 hours. You remember the data telling us too early is not really good. We try to do renal profile on day 2. You know that the renal profile on day 1 is more maternal than the babies, and then immediately refer to urology. So all that has to be done as an inpatient. Some details are in the guidelines, how to contact the urology team, and only based on these investigations and urology advice, we then take further action. The moderate group includes females with bilateral renal pelvic dilatation, now to up to 15 millimeters. Back in 2010, it was 10 millimeters. So you see, by constant monitoring and evolving, we were able to relax a bit our guidelines. And female infants with unilateral of more than 15, and we can include males here as well, because if it's unilateral, it's unlikely to be due to a PUV. In this group, we do start them on trimethoprim. we do ultrasound at the end of first week, because we want the kidneys to be volume challenged, and then another one at 6 weeks, and we refer them to urology at birth. So urology team then decides what to do after that. The low risk group, it's females with bilateral dilatation between 10 and 15, or male or female with unilateral 10 or 15. And these babies don't need to start trimethoprim. They are the low-risk babies. We do 2 ultrasounds, end of the first week, end of 6 weeks, and then we review that in telephone clinic, and we discharge them afterwards. If so, they don't really need the appointments. We do send a letter to GP. The letter is looking like that, informing them what happens. So all the GP knows, and also family what's happening. Basically saying we are doing those scans, somebody will review them, and then we'll make a plan and arrange follow-up if necessary. When we do the telephone clinic, we discharge if renal pelvic dilatation is less than 15 millimeters on both scans, so kind of within normal after birth. But if it persists, if there are any of the other additional findings like calyceuroureteric dilatation or parenchymal thinning, then they need referral to urology, and plus and minus starting trimethoprim. So then this aspect makes them high risk, and therefore they become a higher risk. They become members of the moderate risk group. So this is the protocol. In summary, in low risk group, no trimethoprim, ultrasound at end of first week and 6 weeks. In moderate group, trimethoprim, ultrasound first week, 6 week, and urology follow-up. And high risk, trimethoprim, ultrasound within 48 hours, renal profile, and immediate referral to urology. Where to find this protocol? It's included in our neonatal manual. There's a hyperlink if you wanted to go straight into that, and also on ClinEB. Highlights and pitfalls of our protocol. Well, we think it's clear, it's easy to implement, and we think it's safe. The challenges are that the low-risk group, they have no appointment, no actual meeting with the clinician, which makes some of the parents anxious, and it really strongly relies on the communication and handover. The challenges we've identified over the years is that the antenatal plan is not followed. Somehow whatever was decided antenatally does not filter through to the postnatal notes, and the guidelines, the indications are not followed. We've done various safety measures. Plans in maternal notes now should be on Bargenet. EON midwives are aware of the protocol. It's part of the postnatal induction. Radiologists are familiar with the protocol. And we do continue monthly MDT meeting with the fetal urology and urology team, and I am the member of that team, so we kind of continue monitoring. We've done quite a few audits, and there is still ongoing prospective audit and vigilance. Just to let you know what the audit's findings were, back in 2012, 13 and 14, we had about 10 babies picked up with the low risk, because the higher the moderate are immediately linked into urology, so we worry about the low risk. And about 50% of them, more or less, needed referrals, mainly due to calyceal dilatation. There was some duplex kidneys identified. As you see, some were found to have 8 millimeter dilatation or 9 millimeter dilatation, so they wouldn't have been picked as abnormal since the new protocol was introduced in 2014. And just the number of referrals based on the first one or the second scan. These are the things I've been talking. Overall findings about postnatal, about 50% within the low risk group had normal kidneys. Most common abnormality was calyceal dilatation, but unexpected findings were pelvic kidney or renal agenesis, turning out to be duplex or horseshoe kidney respectively. Then, since we've introduced new protocol in 2014, we've done an audit in 2016, and you see only half of the numbers were picked up because the thresholds have changed, and actually all of these babies required further referral. So the question was, are we just perfectly picking up these babies that need the referral, or are we actually missing some? So ongoing surveillance needs to happen. And that would be all. Just take home messages from that presentation. Remember, bilateral renal pelvic dilatation in males above the normal threshold, and normal threshold is 10 millimeters in the 3rd trimester, they need an inpatient evaluation. In low-risk hydronephrosis, there is no need for antibiotic prophylaxis. And the additional findings in any scan, fetal or postnatal, are really significant. So we don't only focus on the APD, the anterior posterior diameter of the renal pelvis. We really need to take into consideration whether there is calyceal dilatation present, although it sounds really benign when you read that report, because they may be really tiny, like 1 or 2 millimeters, but actually, or ureteric dilatation, they shouldn't be there at all. So if there is any calyceal dilatation present, any ureteric dilatation present, or if there are features of parenchymal thinning, that means that the renal pelvic dilatation is so significant that it is infecting the renal parenchyma, they become high risk and they need to be referred to urology. And I think that's all. If you have any questions, I will be very happy to answer if I can.